So I always try to talk about something else, but Charlie and Kojo always want me to talk about doing lateral surgery. So much so that last year I had a little skiing accident, so I had to have a lateral procedure done on my leg. So how many orthopedic surgeons in the room? Raise your hand. So you guys know what this is, right? The neurosurgeons are like, what the hell is that? Is that a knee or or a hip? Don't worry, I felt the same way when the orthopedic surgeon showed me my knee x-ray. I was like, wait, that's your tibial plateau? I didn't even know that you could fracture the bone that way. So these are my disclosures. I have a predisposition to doing lateral surgery, and it's amazing to me how much the technology and the companies have evolved. And these are my disclosures. I've learned a lot from this course. I've learned a lot from doing courses here. I've learned a lot from the fellows. When you think about doing lateral, there's all these things you have to kind of keep in your brain. Everyone wants to be cool, do minimally invasive, no incision, endoscopic surgery. But you have to understand the anatomy, and you have to understand, what you're getting into, because an x-ray might look like that, and you're like, wow, we're going to really correct that curve and do all these things, but you have to understand the 3D anatomy. Is it a trauma? Is it a tumor? Is there an infection? Are things not normal and not where they're normally supposed to be? For example, if you're doing a lateral surgery and it's really rotated, you got to think about things like the kidney, the bowels, the large colon. I mean, these are things as a neurosurgeon we didn't even talk about. The only time we got into the retroperitoneal space is if you screwed up a shunt, and we all did it. But it was like general surgery and urology is kind of where people, if you understand the retroperitoneal space really well, it makes your life easier when you're doing these approaches. So, but it's not something, when we're doing, I never saw textbooks like this when I was in residency. Was all, most of the textbooks that are printed are for, like spine, neuro, brain, orthopedics. There's no hybrid, here's what the abdominal vessels look like. You have to worry about the aorta, the vena cava, what's in the retroperitoneum. What structures are you going to potentially damage? And so when I started doing lateral surgery back in 2007, 2008, there just wasn't a lot out there, and there wasn't, there was a couple companies kind of pushing the technology, but there wasn't like a textbook. You basically learned from going to a lab, just like you guys are going to do today and tomorrow. So there's a lot to be learned, and it's amazing. Even to this day, everyone thinks, oh, we understand everything about the human anatomy. We know what things are like, but when I was a resident, when you talked about the lumbar plexus, this is the picture that, you would whip out from Netter's or Gray's Anatomy. It kind of looks like that, but not really, right? So you have to it's like, okay, they teach you the anatomy so you can memorize, kind of like the brachial plexus. Remember the trunks, the branches, the cord, the posterior cord, anterior cord. We classify and create these nomenclatures, but in real life, it doesn't really look like that. You don't actually see the nerves; they're embedded in the psoas. In that relationship, you really have to understand. And the textbooks are helpful, but they're not gonna actually give you a roadmap. So you have to understand. Okay, now that you know the anatomy, okay, how do you for example, neuromonitoring. What kind of neuromonitoring do you want to do when you do lateral? And when you're doing lateral, what are things you should look for? So those are things we're going to learn this weekend and hopefully in the lab. But it's something I kind of learned by doing both anatomy and then really doing courses up here and getting in the cadaver and dissecting everything out. Just like in this picture, we did, these are all pictures and really cool diagrams that we're able to create here at SSF with the fellows. This is what the retroperitoneum looks like once you've sort of exposed everything. And then we've got K-wires going in through the disc space. But you can see, we've sort of dissected out the plexus, but you can see that's how the lumbar plexus looks like from a lateral view. And again, most of the time when you're doing the surgery, you don't even see it, but it's kind of good to understand, okay, this whole concept that somehow that you can manipulate the nerves and move them out of the way, it's just not going to happen, right? It's in the psoas. So you have to be willing to adjust in real time during surgery so you don't have a lumbar plexopathy, so you don't have a nerve injury. Again, most of this work that we've done here at SSF, we use a lot of the old diagrams and pictures, but that's what they look like in real life. And fortunately, we had the pleasure of having all these great fellows in the last 15 years who helped. This is Sven and Cliff, who helped. We would dissect. We'd come in on a Saturday and do like 4 or 5 dissections, take photos, because those are the books that typically we would, we would look at it and say, okay, well, what does it really look like in real life? And I think that's really helpful for you guys. Again, you guys are in a digital era, which is awesome. So you can go look up, you can use ChatGPT or Grok, whatever your AI preference is, and you can ask, okay, what's the plexus look like? And it'll pull up 100 different images and they'll all be wrong. So you kind of have to know, that's where reasoning does actually play a role. As you guys know, AI does hallucinate, so you have to be able to differentiate, and going to a course like this is going to help you. So, but this is, again, these are kind of, I took these out of Netter, and this one I think was out of one of the Netter atlases, and you can see the stark difference between, what it's like with the plexus and in a cartoon character sort of drawing versus what it looks like in real life. And then this is what a CT reconstruction with, the plexus and the psoas kind of dissected out. We kind of color-coded things. And what's amazing to me, too, is that, and you guys will hopefully see this when you get out and start practicing, is that when you do lateral or you get really good at doing a procedure, the more you understand about it, just like Dr. Cross was showing you guys, SI joint fusions, he's a master at that. He makes it look really easy, doesn't he? The big screws that he puts in and just with and he does that in, that was obviously a demonstration, but he makes it look so easy. It's kind of fools you because you want to go out and do one on your own. But I can tell you that Woody's been doing that's like his 10,000th procedure, right? So you really have to, and hopefully when you leave here, these are hundreds of cases, sometimes thousands of procedures that we've done. And so it takes a lot of experience to learn and understand, but it all goes back to the fundamentals. So you have to understand the anatomy, you have to understand the approach. And then for me doing lateral surgery, what's really interesting is each patient is totally different. Their plexus is completely different. You could do, like I just did one we did one the other day with Mohsen and I did. It was L23. It took us 10 minutes to do it. And we were docking on and I could see like a huge structure, and I was like, oh my God, what is that? And we were lateral, but the ureter was just in front of us by like 1 millimeter. So there's all these things, and if you don't know that, you can easily, I could see someone just boving or bipolaring the thing. I mean, it was very subtle. I had a little fat around it. Is it a nerve? Is it a vein? And each patient is very different. And I like to show this picture of Jens. He's not here, but this is his cousin and him. You can see they have some similarities. Jens has more hair than his cousin, but then his cousin has facial hair. Jens couldn't grow a beard if he tried. He just can't do it. He's got some genetic thing, but his cousin can do it, right? And if you took these guys' lumbar plexus, I can tell you they're going to be totally different. So just to reiterate, every time you do a surgery, it's unbelievable, like how different human anatomy is. And so you really have to understand it. And because we did so hyper-focused on learning how to do lateral, we put together, thousands of images, tons of dissections. We have an advanced lateral course every year. We've been doing it for like 16, 17 years. That I worked with a publishing company called TIMA, and we published this. So now we have it's surgical anatomy of the lumbar plexus. So it's probably one of the most, reference books in lateral, just because we put so much in there, and there's so many diagrams. But this was done here in the lab up here with the fellows. We put K-wires across to show you that's what it looks like when you're doing a lateral procedure at 045, where that's on the lateral. This is like the freeway in Los Angeles. You have the Santa Monica 405. This is kind of scary to think about, putting a tube, you're putting retractors in. It's amazing.
How did you do that? How did you make the nerve start?
Those are K-wires. So we dissected them out, we colored them, and then we put K-wires in just to show you, how, because when you're doing lateral, you don't ever see the nerves, and maybe in the future, we will be able to see them, have them light up in some way. But, and again, we did a bunch of different, approaches and tried to figure out, like, for example, we all know now, you guys should know this, L4-5 is the most common area where you can have an injury because of the femoral nerve and the proximity of the disc. L3-4 less and L2-3 less. So these are things, whether you're doing a oblique, lateral, even a TLIF, it's good to know the general kind of location of these structures. And again, I think, hopefully, you guys will, part of this weekend is you get to rub elbows with, the neurosurgery fellows. You guys are ortho. I've learned so much from Woody, David, Amir, the surgeons at Swedish where I work. I learned a ton from this guy right here, Keith Mayo. So he's one of the godfathers of the hip and pelvis. And then there's Thomas Schildhauer, one of Jens's fellows. And I know Woody did a fellowship with Jens. But it's this breeding, cross-fertilization. I don't know the first thing about that. And I'll tell you about, the pelvis and the hips, right? I mean, it's just something we don't really understand. The orthopedic surgeons really understand it well. And if you're going to do spine, you're going to do complex surgery, you really have to understand these dynamics. And we're not taught it during residency, but you guys understand it. Like you do hip fractures, you understand hip contractures. I mean, all these things, the hip plays such a vital role in the spine. And, God bless Dr. Dubussé, unfortunately passed away this year. He used to come here every year. I mean, he would talk about the 3D, the cone of economy, and he would get really fired up if you start talking about balance and then start talking about pelvic incidence and sacral slope, because he was like, look, each human is different, and you can't just say it has to be this number, because you could be, it's unique to each person. And so trying to, again, this is where I think the ortho and neuro thing is really important. And what we try to emphasize at this course is, even as an orthopedic surgeon, it's good for you guys to understand, okay, what's the plexus? It's not something you can ignore. It's something that, just like we don't understand the hip and pelvis, it's a vital role and very important structures to know. And again, I think for me, just being around, really smart people, and when you guys get out and practice, when you're going to do that big case, involve your orthopedic surgeons. I mean, who cares if they get, what is it, like 60% of the total surgery and you get 60%? It's so much funner. I mean, Jens and I and Amir and I operate all the time. I have a blast because I can make Jens do all the pelvic screws and all the stressful things, and then I can come in and dissect, the dura, or do something, screw around with like a nerve root, and not really, and you can make it fun, make it collaborative. So, and it's less stressful, right? So you're kind of both have a burden. And I think especially in the first 5 years of your practice, you don't have to do all the big cases that come in by yourself. Include your partners, and again, if you're ortho, include your neuro colleagues. It just makes it a lot funner, and you'll enjoy it. You'll have a longer career. And then I'm going to just go right to some of the cases so you guys can see. But this is, again, this is a cadaver dissection, and you can see this was a corpectomy that we did. But you have to understand, okay, so the plexus actually looks like that, right? So you're not going to be able to dissect the plexus. And so when I do a corpectomy, I'll take the discs out, and that's what I'm doing here. I'm doing discectomy, but I'm mapping out the plexus so I know where it is. And so here it's posterior to me, and basically here would be kind of like where that's I think that's the L3-4 disc, so it'd be the orange there. So that's kind of your working channel. But that's what it looks like. And you can't really, retraction is a problem. So you can't sit there with the retractors wide open for, an hour and a half. You got to get in there and get out quickly. Again, neuromonitoring is helpful, but it's not, it's not going to tell you, oh, the femoral nerve is, has a lot of pressure. You should come down on the retraction. But these are things, when you're doing the surgery, you kind of have to keep in mind that you're surrounded, by nerves and structures that can be damaged if you're not careful. So you want to try to get in and get out quickly. And here's some more nice diagrams, and you can see it's pretty scary, isn't it? Like to think that you're going to do a lateral procedure. So when you're doing lateral, absolutely use neuromonitoring. And listen to it, and understand it. And I always tell people, like, if you're doing a lateral surgery and everything is green at 4-5, then there's something wrong. Okay, like there's no way it's going to be totally green. So and when I'm doing like 4-5 or L3-4, if the neuromonitoring is going crazy, that means you're in the right spot. And when I first started doing lateral, there actually wasn't good neuromonitoring. So what I would have to do is I used a microscope, and I would go down and I'd dissect down through the psoas, and I would find the femoral nerve, and then I would put the retractor just anterior to it. So, going through that, and you can still do that today, maybe early on, and maybe in the lab, you guys can take a look. So, understanding these structures and the locations is really important, and knowing, okay, what are the risks? So for example, if you're doing, an O-lift versus a lateral versus a T-lift, kind of what's the, what patients, are going to benefit from a lateral versus a T-lift versus going anterior. So I don't, I have a preference for lateral, but I also do lots of A-lifts. A-lift is a great operation, right? And that's another procedure where we have at Swedish, we have two great access surgeons, and it's awesome. I get an espresso, I relax, and then I can hear them bitching about the exposure. The fellows there sweating, retracting, and then I walk in and I'm like, awesome. They're like, Dr. Oskouian, we're ready for you, and I go, okay, great. And then you scrub it in, you take the disc out, and then they have to close. And then if they have a hernia or if there's a problem, you can blame them. So again, like when you're first starting out, hopefully you guys will learn this weekend, don't do that OLIF or lateral for the first time by yourself. Like, you guys are smart, do the OLIF with an access surgeon. You probably haven't seen this, but if you read the fine label on all these procedures, they actually put that in there, right? So they don't recommend, the companies don't recommend that you do the exposure by yourself because they know, okay, if you're doing an OLIF, what's the biggest risk of an OLIF? Who can tell me? Is it a lumbar plexus injury? No, it's the vascular injury, right? Because you're going anterior. So, these are things, when you get out in practice, you're probably not going to learn in fellowship. But, these are little things that you're going to pick up along the way and do things that you're comfortable doing. I would not recommend that you go out and do a lateral L4-5 like the first time, and you never did one in residency, you never did one in fellowship. That's not a great, you can really injure someone. And if you have a femoral nerve injury, that person's leg is like dead. The only thing they'll be able to move is their foot.
Lateral.
Yeah. So
Okay, yeah, that's good. Now it's time.
and so those are the kind of things hopefully when you guys leave here. And again, I think
hard to use this because
doing
it's so
lateral is a
tight.
great
There's no,
operation.
real.
Just like any other surgery, when you get really good at it, I can do 3 levels
Thank
of
you.
lateral in
Watch
like
the sharp.
45 minutes.
There you go.
So it's definitely it's a great approach, and I want you guys to learn it. And then not to scare you guys again, but this is what it looks like, with the psoas, and then this is with the psoas gone, and this is an cool behind the scenes. So you can hear Ben's back there. This is the rest of the team. You guys will meet Gary. That's Alexis, Corey, and then Hannah. Linda used to work here, and then. Again, these are cool 3D pictures that the fellows did here. But you can see, this is really, really complicated, but yet it's very doable, right? You just have to understand the anatomy and the relationships. And you guys the cool thing about, I think, in your position is you have access to all this stuff now. And it's online, it's on your preference, Chat GPT, Grok. You guys have access to so much stuff. And I would encourage you to go to as many courses as you can. Whether it's company sponsored here. We have a ton of stuff on YouTube. Who's seen our courses on YouTube? Raise your hand. It's pretty cool, isn't it? You don't have to have a login or membership. You just click the button and you can see Charlie and Amir live, But I think, that's the future, and you guys are going to be way smarter than we were. We were lugging around textbooks. So I think that's it. Anybody have any questions at all? Yes.
Hi, I'm Sean from PMC. When I talk to people who aren't as keen on doing the lateral, a lot of times they'll say it's because no matter what you do, you're going to have some patients with that anterior thigh weakness just from the traction approach. Have you noticed any pearls in developing your technique that have reduced that in your patients?
So that's an excellent question, and my patients never have any complications. No, I'm just kidding. So they will all wake up with hip flexor weakness 100%, because guess what? You're going through the psoas muscle. They're all going to have anterior thigh pain and numbness, so I put them all on gabapentin. And I usually do 900 milligrams at night because then it doesn't make them drowsy, and they just go home with that, just like a pain med. You just make them take it. But they're all going to get it. And I think what I've learned is if you tell the patients you're going to have this issue, they're fine with it. You know, it's just like when Jens does a C1, C2 fusion, they become numbskulls and their necks hurt. If you just tell them that, then they're fine. You know, because they'll be like, yeah, the back of my head is numb because you cut the C2 nerve. I think that's the key thing. But they will all get that. So.
And also, we published, I don't know if it's out yet, but we did a recent study where we looked at patients that had trans-psoas procedures, and we looked at the actual diameter of people that come back years later with a repeat MRI.
Yeah.
And our expectation was that there was going to be a significant decrease because you're traumatizing, but we actually did not find that. You know, some people, you address their spine pathology, they become more active, and that psoas can recover and actually grow in size. Between those, it was not a big difference because there's such a variation, but we actually did see a significant increase in terms of the psoas diameter after a trans-psoas procedure, which was a surprising finding. So it's going to be variable, but absolutely, I think the you know, communication with the patients is incredibly important, and definitely, you know, tomorrow in the lab, I had a case recently where the femoral nerve kind of slowly worked its way into my surgical field throughout the case, and that was a little surprising. But you know, here in the lab, you can see that, know what it looks like, and you know, you can really be more prepared if you are doing these cases on your own.
But really spend a lot of time in the lab. I mean, learning how to do lateral corpectomy will change your life because you don't have to rely on an access surgeon, and you can do it yourself. It's a great operation. Charlie.
Yeah, I was just commenting on Amir's study. I wonder if maybe the psoas muscle got fatter as a result of improved lordosis. You know, like because it's no longer getting stretched. Maybe that would be interesting to see if the muscle size increased with lordotic change.
Yeah, I mean, Luke was here actually. Luke is the one that was looking at it. He stole your guys' QR codes. He's around, but it was really interesting. So, any other questions at all? I hope I didn't scare you about doing lateral. It's actually a great operation. So, cool.
So I think.